Can everybody online hear us? Just want to check the IT. Yeah, great. Smashing. Recording has restarted. The meeting's back in progress. Turning to the next item of the agenda, item 31, working in partnership. And I hand over to Chief Executive for firstly an update on the provider collaboration.
Yeah, thank you, Chair. So this is the second or third iteration now that we've been produced from the collaborative that the Managing Director, Jonathan Wood, creates, that's consistent for each of the boards and provides a bit more insight into some of the work programmes progress to date and the benefits that we should see from the collaborative. So you'll see from an operational and financial performance perspective, there's an outline of the broader system financial position and where each of the trusts sits. From the perspective of the financial contribution of the provider collaborative, two things to note from the last meetings. One is the reduction of 30% in the contribution each trust makes to the running costs of the provider collaborative. That's intended to release it's about £2 million worth of cost back. So we've restructured that and it sits within our CIP programme. With some challenges around how we then can continue to deliver the work programmes that we've set out to achieve. There is then a piece of work that the teams have done to outline all of the schemes that the provider collaborative are currently overseeing and the value of those schemes. There's about 91 all told across things like the clinical programmes, the clinical support portfolio, things like pathology, digital, to a value of around £45 million worth of benefit. That is yet to be completely validated and cross-referenced with our own CIP to make sure it's deliverable, releasable and not double counted, but confident a good proportion of that. I think at the minute, from our perspective, there's about just under £3 million reflected in our CIP. More to go, but we need to validate that and make sure that we can access those. There are two key pieces of work that the collaborative have sponsored the last 6 months, which move away from purely oversight of key programmes of change and starting to talk about being greater than the sum of our parts. So there's a collaborative productivity series. So that's looking at ENT, general surgery and pain management initially. And that's looking at best practice pathways for outcomes and cost, lifting the best of the system to the rest of the system. So our clinical operational and improvement colleagues are just starting to move through waves of what I would call shared service improvement methodology. So I'm looking forward to seeing how that progresses. And then we've got the resource-based planning approach we've talked about here before. It's a similar methodology, but more targeted on things like the bigger service areas like trauma and orthopaedics, which we've piloted in Blackpool. We're just starting to take that into our own organisations now. There are some areas of business that are highlighted in the report that we're touching on later on, particularly one LSC and pathology, which we have in part 2 for a conversation. And you'll see in the clinical service programme development, we have 2 clinical service changes that are proposed to complete with commissioning support and subject to an HSE gateway decisions. That's the vascular specialist services that will transfer to Lancs Teaching, and orthodontics, which will be creating a hub and spoke arrangement to try and manage fragility of workforce and create a Lancashire South Cumbria wide orthodontic service. Both have had support from the collaborative and the commissioners for commissioning interventions. Appendix 1, I'll draw attention to because that's a combination and a summary of all of the pieces of work that we did in 24-25, just to bring to life the work of the provider collaborative. And the latter part of that appendix provides us a forward look for 25-26 and the key programmes that we're taking forward. That will feature in updates in each of the monthly PCB reports so we can track progress. We'll also make sure that whilst we've delegated authority to joint committee and the subcommittees of the provider collaborative, particular programmes of work, where we have programmes that require board oversight or support for approval, we'll continue to use our governance processes for that. But I appreciate it's still a new way of working and that devolved autonomy and that governance and assurance oversight we're still working through. So that's as much as I wanted to say on the PCB agenda item.
Great. So this is coming to us to note. Everyone happy to note it? No comments, Sarah?
Thank you. Thanks for the update, Aaron. I had a question actually about the orthodontics provision. So I'm just trying to get back to the paper, the page in the paper. It talks about going to a hub and spoke model, as you say. Great to see actually Furness being recognised as one of those, actually just recognising that sort of dispersed population that we have. What I wasn't clear about is where the central Lancashire hub will be, because it doesn't actually say that in the paper. So, and then my question actually, so is A, where that would be, and has consideration been given to how people will get there, noting that not all of our population has a car and buses don't run outside of the main point, sort of main cities and things like that, or they don't run, but it becomes more problematic.
So there'll be two hubs, so at East Lancs and at Chorley for Lancs Teaching Hospital, and the satellites at Blackpool and Furness General Hospital. The commissioners oversee the quality and equality impact assessment to ensure things like access and health inequalities issues are addressed as part of the proposals. So as we work through the final considerations with the ICB will take responsibility to ensure that that is the case. If it isn't, it can't proceed in the way that's proposed. So that's the governance structure.
So if you lived in South Lancaster and you didn't have a car, you'd have to either get to Barrow or you'd have to get to Chorley or Blackburn to use that service. Yes,
that would be the case. But at the moment, patients in those areas can't actually access services. There's waiting times of 2-3 years at the moment. So there's a balance risk that commissioners will have to assess, not here, around the potential disadvantage and how that will be managed for access versus the not being able to access any service currently. So the proposals are designed to introduce access to services that don't currently exist. So it's not a movement of you have a service, you can access it, we're going to move it. This is, we can't provide services. This is the proposal to try and get service provision more broadly across the patch, but the equality impact assessment and the commissioning responsibility for that still sits with the ICB to manage that. So it's a system assurance process. It's a commissioning assurance process. Yes, that's what I mean. Sorry. Yeah. Okay. Thank you. That's really helpful clarification.
Any other points or questions? If not, we have the terms of reference for the Provider Collaboration Board to approve. Are we happy to approve those? Yeah, great. Moving on then to item 32 on the agenda, the Board Assurance Framework. Can I ask the Company Secretary to introduce the item?
Thank you, Chair. The Board will remember that earlier this year, the Board approved a revised risk appetite statement, agreed strategic risk to agreement objectives and areas of focus for this year, and agreed a Board Assurance Framework. In May and June and through into July, that Board Assurance Framework has been developed, and what you've got in your pack is a covering report that sets out kind of the areas of focus on what's been taken through our assurance committees and through our governance processes. I'm not going to go through that report in detail, but I just want to kind of really triangulate the paper with a number of the discussion points and areas of escalation and risk that have been reported in previous items. Matters like not meeting criteria to reside, some of the assurances from quality committee and areas of focus for that. I will call out the coding issue that Ali mentioned. That's going to feature in the Board Assurance Framework as an area of focus and assurance in the next phase. In addition to the change programme that's been sponsored through UHMB executive team, we've also now captured as well the change portfolios within the PCB, which is set out there. Again, there are a series of mitigations which are set out there. One LSC featured in the government report. Again, we've discussed that, and there'll be discussion in part 2. Variety of discussions around the waste reduction and financial improvement plan delivery. Again, those are captured in there. Other areas that will just draw your attention to, we've developed a stronger narrative now, and you can see greater visibility of our governance and assurance arrangements around capital, more visibility of the capital plan, the areas of investment, areas of focus. I just want to reference there the estates optimisation programme, which has been now initiated under Helen's leadership. Under Ali's leadership, we've now got greater visibility of kind of the delivery plans in respect of digital, together with various mitigations and where those will be tracked. And then lastly, there's a narrative around partnerships, but the one area that perhaps just want to pick up on is really where Aaron started. The 10-year plan will be coming out. I think there are political and partnership risks that will need to be considered, the way that Aaron articulated at the development session that will be taking place later in the year. So that's a very quick overview of what we've captured in the board assurance framework. We asked each of the assurance committees whether or not we should be changing any of our scores at the early part of 25-26, and there was a view that whilst there is clearly a lot of work underway, that we can't really change any of the scores, either up or down, until we've got a better sight of the impacts and the trajectories that we might see during later in the year. So that's the report. I'm happy to take any questions at this point. Thank you.
Thank you, Paul.
Just to ensure or remind the board that we do have a quarterly assurance process. So I want to make sure with Paul and colleagues that we are still putting in place that review. It's normally July, August, October, November, and we step back, don't we? We look at the strategic objectives, the delivery plans for the annual plan, and revisit the BAF risk framework at that point. I think once a quarter is probably the cadence that you could do with a bit of objectivity for some evidence. We may also, Chair, think about doing that more formally every 6 months, depending on the strategic items. But just to reassure boards that we have our quarterly strategic review assurance process that will be taken.
Great. Any further points? Karen?
Oh, thank you, Chair. Just to highlight, and this was a point that we raised through People Committee, is we're conscious that the formal staff engagement metrics that will inform risks and the BAF may well only be captured for those staff employed by our trust, but we know that we have staff working here employed through other service transfers, and it's just really highlighting some of the challenges in making sure that we've got a comprehensive data set, not just of those who are directly employed by the trust, but those who are delivering services for us. So it's just to highlight that's something that will potentially need some further thought going forwards, so that we get that comprehensive set of staff engagement metrics informing our strategic risks.
Yeah, Ali.
So I'm just picking up on Aaron's confused face. So, so this is because the staff survey is done based on the people who are employed by you as an employer, but we obviously have a significant number of people who work in our teams. So particularly those who are employed through ELHT, through 1LSC, who we would class as in two teams, in a 1LSC team and in a Morecambe Bay team, and we wouldn't capture those individuals in Morecambe Bay's staff survey because they would be falling within the ELHT survey. So it would have just to really be cognizant that we need to find ways to ensure that we are capturing the sense of feeling from everybody who is working in a Morecambe Bay team, even if their employer isn't Morecambe Bay.
Just to take that up, I really want to understand the governance and how you do that, because my understanding of the construction of 1LSC and the LHT employment model would be that the staff survey would be issued by LHT and the colleagues would feed back through that employment model, and then 1LSC leadership team, of which we are part, would then take that feedback and talk about improvements or reflections, etc. I just want to, probably not for here, just explore the how and the why we would seek to do something outside of that, or whether it's dovetailing with that process and ours to get the composite view. But it'd be good just to explore. It's just to explore that.
Yeah.
Let's continue that conversation offline. Thank you, Karen, for raising that. Any other points on this agenda item? If not, we'll move on to item 33, the membership strategy for 2025 to 2027. And can I ask the Company Secretary again to present?
Thank you, Chair. Foundation trusts are membership organisations. We have staff members and public members. And as part of our framework under which we operate, set out in the NHS Code of Governance, we are recommended to have a membership strategy and to keep that under review. A piece of work has been undertaken by the Foundation Trust Membership and Communications Group, which is chaired by Susie. They've had a review of the paper. It's gone through a process. It's gone through our Council of Governors, and the paper is presents to you the revised strategy, which is here for approval. I think it might just be appropriate, Susie, given that you kind of led on this, to just invite you to say any particular comments or areas you think are relevant for the board to acknowledge.
I think we know that we have a difficulty in connecting with members and with our constituents as a whole. And that's one of the things that we're focusing on. So we did have a look again at the framework to see if it was fit for purpose, as it were, and we made a few tweaks which we thought did sort of help. And what we're going to, we hope, do is work in the membership in this particular group to try and come up with some ideas actually how to act on this. And Lou and I, particularly in connection with this, and we're already actually starting to send out little and often, rather than large chunks of information to our membership, to try and get people who are members to actually act and come in. And we're particularly aiming for the annual membership members meeting, which we're taking online this year, we hope. That's the idea, isn't it? So, yeah. Like a Teams meeting. So we're hoping that we're actually going to leaner and meaner, shall we say.
Excellent. Any questions on the membership strategy? No, if not, thank you particularly Susie for the work that you're doing to engage with our members and refresh the strategy, working with the team here. I think that's really important to ensure our members understand what the trust is doing and how we're driving forward improvements.
And how they can help. I think that's the important thing, is getting over to people, this is your trust.
Yeah.
That's all the sort of thrust of it.
Excellent. Okay, moving on to item 34, the Chief Medical Officer's update. Can I ask the Interim Chief Medical Officer to update us?
So Guardian of Safe Working annual report, obviously in the pack for a couple of things. So it mentions that we have our exception reports from our resident doctors have gone up from the previous year to this year from 331 to 368. Now we're pretty certain that that is because we now include all voluntary employment. But obviously we'll continue to make sure that that's continuing to rise. 90% of those exception reports are due to hours worked and lack of rest between shifts. So that's gone back to the divisions, and that work is now being completed one-to-one and all focused to be reviewed. So we're hoping that will decrease. Other things to mention that was highlighted in terms of alerts. So there has been multiple issues in terms of office space, in that everything's always digital and right now it's etc. That has been escalated to the space utilisation group, and same with the mess facilities, in the fact that we've increased in we've doubled our resident doctor numbers over the last 5 years, and therefore we just don't have enough space. We need them to go into suitable rest facilities. Now it's no secret that space is an issue across the whole of the bay, so we haven't really got any mitigations for that, but it's just so that you're aware of it. And finally, on that report, so the new terms of service that we agreed with the resident doctors last year as part of the pay deal, the Department of Health and Social Care have given us some recommendations which we need to be able to address and give assurance to them by the 12th of September. Includes things like exception reporting, the level of management escalation they go to, how they get the time back that they work extra. And all of that's been ratified in divisions currently. We are on target to give assurance to the Department of Health and Social Care that we practicalities of that sort of by the 12th. In terms of the research and development report, there's some really good news from this. So this is obviously the annual report across the last year. So we have now opened studies in life sciences, rheumatology and surgery, which is the first for the trust in the last year. Usually we're very fully on oncology and respiratory, so that's really exciting. Other things to say, which I think we've brought to board previously, but we got a first in Europe and a second in the world of recruitment that is Morecambe based. So we are punching well above our weight in terms of where we are and what we do, and that's including London, obviously. You really have a lot of investment into research there, so we're very proud of that. We currently have 48 studies, 8 of which are commercial, so that's where all the money comes from. But we are very mindful in terms of our geography and our ethics that we don't fully invest in commercial studies, because obviously, although that brings the money in, it's the local things that for our local population that really carefully. So it's about balancing the three for there. We have a new head of research that started in Trust yesterday, Nicola Australian, after Andy Lancaster's retirement last month. She has done an incredible amount of national work, including with the National Institute of Research and regionally, so we are very excited with Trust, so I expect things to improve as we go forward. And sort of on the back of the National Director of Clinical Transformation for NHS England, there was a paper that came out a month ago about fully supporting and investing in research despite sort of the finances, and we're hoping that with the 10-year plan, in terms of being able to have a longer sort of financial plan in terms of 3-year plans, we might look to start putting in papers to say if we invest in clinical nurse researchers and we spend £108,000 over 8 years, we might be able to bring significant more amount of money back into the trust. So currently the trust funds about 50% of that department, and we're hoping that by investing in extra staff and people will be able to actually take just that money out of the department, will be self-sufficient. So there will be papers coming soon on that.
Great. Thank you very much. Any questions?
Yeah.
Yes, sir.
Thank you. Thanks for the update. So this is for the second paper, the research and development update. So it's sorry. We had a board development session on research and development innovation. Probably, I can't remember what it was, maybe about a year ago, I can't remember. And at that time, we talked about the focus being primarily on the patient, on the research studies, essentially in the patient trials, and that actually there were other opportunities for research and development, which might help us support us in terms of innovation, in terms of clinical practice, pathways, etc. And they can also support retention or recruitment of particularly medical staff, I think, where you can have those potential joint appointments, honorary appointments, etc. And I suppose I'm not seeing any sort of update on that reflected in this report, but I know that Andy Lancaster's just retired or finished, and we've got a new head of research and development. So are we looking at that being an area for development? Is that something you anticipate the new head of research and development will start to look at? I'm particularly interested in probably, I can see there's a stream of work that relates to allied health professionals and nursing, but actually probably thinking also about the medical workforce and also things like health inequalities and the work that Chris is doing. There's a huge amount of opportunity for collaborative research out there, and do we have an aspiration and ambition to build around that?
So yes, so we have monthly meetings with the University of Cumbria and the University of Lancaster, talking about the opportunities there, which includes them giving us opportunities in terms of training principal investigators for the trust. So that work is already in progress, and we have recently got some money, haven't we? Emily,
in IHR.
Yeah.
Yes, funding.
So which we have 2 days a week of specialist input in there in terms of basically making the trust of research more research ready, and do that and bringing that into the department. So that started 3 months ago.
3 months ago.
Yeah. So it's on.
It's progress. It's going really well, Sarah.
Yes. Okay. That's great to hear. And is that an NIHR investment focused primarily in the nursing and allied health workforce? Okay.
Yeah, in the module.
For the work with the universities that we're currently leading in those monthly groups with Jez from Lancaster, for example, will be more focused on.
Okay, thank you.
Great. Can I bring Karen in?
Oh, thank you. And it's not an assurance point, but just to add to that conversation, Sarah, and to confirm what Tabitha was describing, I've, as the Ned lead around research, being involved with the work that Dan West is doing with Tabitha, and particularly the really strong focus there to really try to promote research literacy and action research. So really thinking about research opportunities that could be really strongly aligned to some of our service improvement activities. So it becomes action research kind of with, for and in practice. So it's early days, but I'm really sensing a very strong direction of travel in that space.
Thank you.
So we've had this conversation quite a lot, and I'll frame it in this way, which is, are we maximising the potential for research in our organisation? Because our potential is restricted slightly, not necessarily by size and geography, but actually our local universities don't have biomedical research infrastructure. It's not like Liverpool, Manchester. So the reason we gravitate more towards population health, like the respiratory network, allied health professionals and nursing, is because that's our academic partners' kind of specialty areas that they would want to engage in. So we don't get the kind of professorial appointments or the clinical research appointments of the scale and depth that you might get in a different type of unit. So I think when we have updates in the future, to answer that question at the outset is to frame what we think the scope of opportunity is and how we're maximising that. Because it does feel like a perennial thread that we pull when we talk about research. I think it'd be good just to kind of bottom that as a baseline. So right, well, here's the maximum opportunity we've got given our portfolio, the structures we've got, the academic partnerships we have, and here's how we're maximising that. Now, there is a conversation to be had around wider partnerships and using the collaborative and what things like the hub and spoke arrangements and the tertiary arrangements that will develop in the future might give us, which should also feature, I think, as an opportunity for the system. But it'd be good if we could just kind of draw that to a bit of a point, I think, in the next update.
Thank you, everyone. If no further comments, we will move on to item 35 on the agenda, Policy and Publications Report, Chief Executive.
Thank you. Just for noting, Chair, there's nothing in particular to highlight in the publications report.
Great. Okay, moving on to item 36, the Freedom to Speak Up Annual Report. Can I turn to Tabitha?
Oh, thank you, Chair. I think everybody's seen the report and the pack. It's been through to people and culture, and it's also been to quality committee. There's only one point to sort of highlight that came through people and culture around our anonymous concerns and resolution challenges, where we need to focus a little bit so we can get effective resolution. So that's one area that was raised as an area to sort of improve, but there is a significant increase in concerns after Speak Up in month October. I think it's going well, but we need to just monitor with the changes that are coming nationally around the Speaking Up Guardian Office, and how, as an organization, we continue to do the work that we've been doing as part of our improvement journey. I haven't got anything else to sort of say. It's just here to give board assurance as an annual report to say we continue to promote freedom to speak up.
Great. Are we happy to note? Can I bring in, sorry, Karen, and then go to Ben?
Oh, okay. Thank you. Just in support of Tabitha's comment there, yes, the People Committee were particularly noting the number of, or the proportion of, anonymous concerns, probably approaching a third of the concerns raised. And what we're keen as a committee to see is, as the leadership and organisational readiness programmes begin to really gain some traction and implementation around our divisions, that the potential for that to address some of the root causes of anonymous concerns. So we're looking to for triangulation of the implementation of those programmes and any potential impact on anonymous concerns through Freedom to Speak Up. So we'll continue to monitor that as the new programmes become really embedded.
Thank you, Karen. Tabitha, do you want to say anything on that before I bring in Ben?
No, Karen has actually covered it, so.
Brilliant. Using my chair's discretion to bring in Ben.
Thank you. Just as a follow-up to what Karen's added, really, so at the People Committee, there was just one question posed. I don't know, Tabitha, if you got the answer on that, but what was refreshing to see within the report was a mention of, in the priority actions, the need for targeted guidance on how to submit comprehensive and meaningful anonymous concerns. So I think it was well recognised that rather than just saying we'll outright try and reduce anonymous concerns, that actually we try and improve the quality of them. But the question there is, how do we target something that's anonymous? So how are we going to get that improved way of submitting anonymously out to all colleagues, because we don't know who is actually submitting it anonymously. And then also just to recognise what Tabitha picked up on about what's been said in the national picture in the last week around the future of the Guardian's office. It'll just be useful, I think, to have assurance moving forward around how we sustain the improvement journey we're on should we face losing Guardians because of the closure of the National Guardian's office. Thank you.
Thanks. Tabitha.
Thank you, Chair. Thank you, Ben, for that. We actually have a meeting with Nicola, one of the non-executive directors, myself, and the Guardian team to look at, they've made some suggestions in terms of how we can improve the anonymous take and what actions they're going to take. So we're meeting prior to sending some actions to People and Culture, again, in response to that. And then secondly, in regards to the Guardian office, at the moment, we don't know what steps we're going to take as an organization, because nothing is coming from national office to sort of say freedom to speak up has to go this way. They're just sort of saying the oversight of that Guardian office is not going to be there. So it's about ourselves as an organization in terms of how we have the reporting and the oversight internally. Or who else from national office will take that responsibility. It's not clear at the moment. And we'll keep board through People and Culture posted for any changes.
Thank you, Tabitha. Are we happy to note item? If we are, we'll move on to item 37, the mortuary assurance return from the Chief Operating Officer, Scott.
Thanks, Chair. It's here on a consent agenda, so it's I won't summarise it in detail. It's one of those idiosyncrasies. There's about 2 or 3 papers a year which need to come to board directly. It's an ask of the Human Tissue Authority that this comes to a board of directors meeting. The recommendations in the last 2 paragraphs are clear. That we're asked to note that the security of our permanent facilities is in line with the guidance. And that the the surge facilities, that's not the case, but there is a business case in train that will make it the case.
Thank you, Scott. Are we all happy to note that report?
Sorry. Has
Sarah.
that come separately? I can't see it in the pack.
Yes, today it was
Sorry,
one of the.
apologies. As you know, I was.
Yes, no.
Today, so-
That's fine. Yes, it was one of the items lately sent out. Are we happy with that? Great. So moving on to item 38. Item 38, attendance sponsor register. Just to note, that's in the pack. And item 39, the schedule of business, again, is included in everyone's pack. So assuming we're happy to note them. I've not been informed of any urgent business. No, nothing has been notified. So the time, date and venue of the next meeting will be here again on Wednesday, the 3rd of September. Also will be people will be able to join via Teams. That concludes the public part of the board meeting. There will be a private meeting later. So for that part of the meeting, we have to pass the exclusion of the press and members of the public. And are we happy to resolve that representatives of the press and other members of the public will be excluded from the remainder of the meeting, having regard to the confidential nature of the business to be transacted? Happy. Thank you very much, everyone, for your attendance.
Thank you.